Morning, everyone. Good morning. Thank you. It's so great to see familiar faces, old friends and new faces, new friends. I am so excited to join you all with this extremely distinguished panel of panelists who are leaders in their own right, trailblazers who have been pushing this health equity agenda forward in all public policies. So, as many of you know, it's titled Minority Health in Trump America. There are certainly many challenges and opportunities that we see right now and ahead as we move forward to promote minority health, to elevate it, and to address health equity moving forward. Now, many of you, unless you've been hiding under a rock the last several months, you remember President Trump admitting that who knew healthcare could be so complicated, right? Very complicated. And guess what? It's even more complicated when we are talking about minority health. So that is why we have assembled this impressive panel of healthcare leaders from across the country to help us peel back the onion and take a closer look at the political determinants of health. So get ready. All right, so as many of you know, the big elephant, the big issue, deals with the Affordable Care Act. You've heard me say this time and time again. It is the most comprehensive health law ever produced by the U.S. Congress, directly addressing the issues impacting disparate groups, minorities in particular. And it's also the most inclusive law that we've ever produced in the U.S. Congress, and we owe it all, of course, to our dear members in the Congressional Black Caucus. We owe it to Congresswoman Robin Kelly, who has been fighting to sustain and preserve the gains that we have made, and her incredible staff. So kudos to you, Congresswoman, and to your outstanding staff. So in terms of what the ACA has, it's a bigger deal than most people, I think, recognize. 62 provisions in this law directly addressing minority health and health disparities. Some of them have been slated explicitly for termination, repeal, and so we're going to talk about that momentarily. And as many of you know, yes, there have been 11 brushes with death that the Affordable Care Act has come up against. And we saw that happen most recently with the American Health Care Act. What does this all mean? We're going to slice and dice this in a moment, but let me begin by introducing our incredible panel. The first is Dr. Ray Bignall, who is a board-certified pediatrician, a clinical fellow in pediatric nephrology, and National Institutes of Health postdoctoral research fellow at the Cincinnati Children's Hospital Medical Center, of course, in Ohio. He is a passionate advocate for child health, involved in a variety of community child health advocacy efforts, and he actually is also a double threat. Not only is he a practitioner, but he is a researcher, and he focuses on the social determinants of health and health disparities in pediatric kidney disease and transplantation. So welcome, Dr. Bignall, to the panel. Our second distinguished panelist is Dr. Robert A. Winn, who is the Associate Vice Chancellor for Community-Based Practice, as well as the Director of the University of Illinois Cancer Center at the University of Illinois Hospital and Health Sciences Center. He's a professor of medicine as well at the University of Illinois at Chicago, and actually in the Division of Pulmonary, Critical Care, Sleep, and Allergy Department. And I think I may be using your services very soon, Dr. Winn, because God knows I've been having allergy issues. So in addition to that, he also engages in research and has been looking at programs that can be integrated in the community. Community-based participatory research is his specialty. He's firmly committed to using community-based health initiatives to drive basic science research and eradicate health disparities among vulnerable groups, including racial and ethnic minorities. He has, of course, led numerous efforts on a number of diverse committees to develop the next generation of physician scientists, so a mentor to many folks, the next generation of scientists and practitioners, and has received numerous awards for excellence in teaching, in research, leadership, diversity, and service. So please join me in welcoming Dr. Winn, please. And our third distinguished panelist is Dr. LaMar Hasbrouck. He is a recognized leader in public health and one of only a few public health leaders in the country that served at every level in government. So from the municipal, the state, the regional, federal, and global levels. And quite impressive resume. He has actually led both the public health and mental health departments in New York State for their health department. He worked 11 years at the Centers for Disease Control and Prevention, directed the CDC's office in Guyana in South America, and was actively engaged in two of our largest global health initiatives in history. So polio eradication and PEPFAR, the US President's emergency plan for AIDS relief. He currently serves as the executive director for the National Association of County and City Health Officials in Washington, which is the nation's only association representing nearly 3,000 local health departments across the U.S. And they're responsible really for protecting and improving the health of over 220 million people here in our country. And among his achievements as State Health Department Director in Illinois, he was responsible for implementing the Affordable Care Act and co-chairing the Ebola Task Force, as well as developing blueprints to elevate workforce expansion and public health and healthcare integration. And he is an author as well, so triple threat there. Authored the book G Street Lion, Stalking a Dream, which is his memoir detailing his life's history. So if you haven't seen that book or you haven't gotten a copy, I encourage you to read it. So let's welcome Dr. Hasbrouck. And then our fourth and distinguished panelist is Dr. Richard Allen Williams, certainly a trailblazer and someone whose shoulder we all stand on, has been fighting the good fight for health equity over the years. And he is the president of the National Medical Association, as well as the founder of the Association of Black Cardiologists, ABC, and actually has served as clinical professor of medicine at the University of California, Los Angeles for over the last 30 years, been really driving multicultural health issues there and within various institutes across the nation. And he too is the author of several books, textbook of Black-related diseases, Humane Medicine, volumes 1 and 2, as well as the athlete and heart disease. And he's, of course, written numerous papers on these issues and has two recent books that are entitled Eliminating Healthcare Disparities in America, Beyond the IOM Report, and The Heart of the Matter, both published in 2008. And he also authored a new book in 2011, Healthcare Disparities at the Crossroads with Healthcare Reform. And so I urge you to also get that as well. And to his credit, he is a frequent lecturer on healthcare disparities, as well as clinical topics on hypertension, diabetes, obesity, and heart failure. So join me in welcoming Dr. Williams as well. So we're gonna open this up by giving each panelist 2 minutes to tell us from their vantage points, what are some of the challenges and opportunities that they see in this new administration and this new Congress to preserve the gains that we have made in health equity and to actually expand on those gains as we move forward. So I'm gonna start with Dr. Bignall and we'll go down.
Well, thank you very much. So again, my name is Ray Bignall. I'm a clinical fellow in pediatric nephrology at Cincinnati Children's Hospital Medical Center. I'd like to first begin by saying a very special thank you to the National Minority Equality Forum for the invitation to come and speak. This is certainly a rather humbling experience to be up here with these remarkable men. And, I'll speak from the perspective of a trainee. As a fellow, I'm perhaps most familiar with, with that role. I've been a trainee now all my life, basically. So there are a few things that I think are salient, certainly in this administration, but it could be relevant for administrations past, but I think are absolutely essential for advancing minority health. So I want to touch base on a few of these. Number one is mentorship in academic medicine. Mentorship in academic medicine. I did not want to become a pediatric nephrologist from birth. I remember one of my nephrology attendings told me one day, I was on rounds with him as an intern at Cincinnati Children's. He said, well, what do you want to be when you grow up? I said, I'm not sure, maybe pediatric hemonc, maybe pediatric emergency medicine. But what I really want to do is to be an advocate and to fight for families who are disadvantaged. He looked me in the face and said, you should become a nephrologist. And you should join a special program we have within the American Society of Pediatric Nephrology called the John E. Louis Fund Advocacy Scholars Program. It's one of the few subspecialty programs designed for individuals who are young in their career in nephrology to learn how to be advocates. Every year I come, I visit the NIMHD, I visit the NIDDK, I visit Congress, and we advocate for issues that are of concern to our patient and our population. It has changed my life. Another program is the National Institutes of Health and the National Medical Association's combined program, the Academic Medicine Fellowship. That also changed my life. Before that, I had no clue what academic medicine was all about. And I'll tell you, a lot of minority trainees, we just don't get it. We just don't get it until we get into it. And we realize we're in over our heads, and I believe that that has something to do with the issues and challenges around retention of minority talent. If you can find a young minority physician, I told this to a gentleman at the NIDDK the other day. I said, I wish you would just put me in a van and take me down the street to my alma mater, Howard University, and you give me 10 researchers in different parts of the country who are looking for someone to work in their lab. I guarantee you I can find 10 excited students who'd be willing to come and do some research in that lab over the summer. We have to find ways of connecting with the young people, the minority youth, underrepresented youth as well, like women in research, and get them engaged around these topics. It's absolutely possible. Each of you can be a mentor. You don't have to look like your mentee. Some of the best mentors I have don't look anything like me. And find them and engage these young people where you are in the different parts of the country. I think that that's going to be essential. So I'll leave it there.
I'll try to keep my remarks brief. I'll start off by reminding all of us that George Washington's farewell address of 1796, probably of all the documents that I've ever been a part of and read, was probably the most important in framing my understanding about what it is that we're supposed to do. If you haven't read that, it's short, it's really quick, and I think it's incredibly powerful to remind ourselves that in this administration or any other administration, that it's really not all about the red or the blue, or focusing only on red or only on the blue, but it's about the people, and sometimes that gets lost. What gets lost in this conversation of sometimes this sort of very politicizing your sort of research, politicizing the sort of medicine part, what gets lost in that is doing things like making a 20% cut or proposing a 20% cut in the NIH budget. Now, the crazy thing about that is that it not only affects people like us who are trying to actually come up with the new sort of cures, who are trying to actually figure out how to get these things to communities, but it interestingly affects my South Side, or whether it's on 63rd and King Avenue or around Inglewood, as much as it does Beattyville, Kentucky. And so interestingly, the cuts and the support for these cuts, I think people aren't aware of because it really will affect all of us. Second, there are things that are happening right now that I never thought in a million years anyone would even broach. For example, introducing a bill that says, we should stop, literally, collecting health disparities data. In fact, we should stop that. Now, there was a level when I first heard that, I was like, that's crazy. I mean, that's what, someone had recently been to Colorado and got some new stuff. What happened? Now, I can say that because I was in Colorado for 15, 16 years. They were happy people, I'm just saying. But I will tell you that you start thinking about the sentiment of collecting health disparities data, and you want to stop that, but the stopping of collecting any data, right, particularly the data that might not show good things for your side or a side, actually indirectly has an impact on the people that you say you're trying to help. It hurts everybody. Second, I think the issue around the State Department, when we talk about global health, we are involved with a program now, an amazing program where we're learning with and from Cuba about how a low-income country could have a life expectancy, in some cases better than America, and we're trying to actually get that on the south side of Chicago, and yet we have to go through the State Department that still, to this moment, is a little bit stuck. You got rid of some of the old people who knew what to do, right? And in fact, they've not been replaced. Lastly, for me, and importantly for me, is this issue around it's not just good enough to talk about what's happening in Chicago in issues of violence and not have a plan. And if the plan doesn't exist in the red states, then at least let the blue states take a crack at what we're trying to do. All I'm saying is that at the end of the day, I believe in the principle set out by George Washington that when we become us versus them, we all lose. And so we have to get back to figuring out how we are focusing on all of us. And I think I'll end my comments there.
Good morning, everyone. Let me join in offering my thanks to Representative Kelly and her staff, who's walking back there, Brandon Webb, for always keeping me in the loop and all the hard work that she does with the CBC Health Braintrust. Let me make one quick correction. I am no longer the executive director of NACHO. I have resigned from there a couple of months ago, so I just want to make sure folks knew that. My comments are really going to be through the lens of kind of public health, population health. I spent 25 plus years working in population health, and as mentioned, have been doing that at various levels. So many of my comments during this dialogue are going to be colored through that lens, kind of the broader context, the broader drivers of health. But in thinking about this post-Trump era in healthcare for minorities, I came up to a question. And the question was, what's in a name? What's in a name? And so I was thinking, I wrote an op-ed recently that was published in The Hill about the dismantling of Obamacare. And when you look at the name of the replacement draft law, which is called the American Health Care Act, you get a sense that it's a law because it's an act, and it's related to American health care or the American health care system, or maybe even the American health care industry. And you get the sense that there's going to be some winners and some losers, and some people are going to be impacted. Now you juxtapose that to the name, the Patient Protection and Affordable Care Act, it gives you a different ring. Number one, to my mind, patient is first. So one might argue it's a patient-centered act. Secondly, protection of that patient is second, right? So you're trying to protect the patient. And then thirdly, you're trying to make sure there's affordable care for that patient that you want to protect. Presumably, those who need it most can afford it least. And so it has kind of a different ring to it, a different spirit to it. And so I think that if there's anything in a name, I think what has been lost somewhat in reducing it to Obamacare and making it a political football is the intent, the motive, the spirit of that initial act. Now, what I'm concerned with and what I am most fearful about is that there's a number of provisions in the Patient Protection Affordable Care Act that really took a ounce of prevention approach to health care. And many of us in this room, I know that you all in this room understand that it's the context in the community. There are drivers and determinants of health that really leads to health. It's not health care equals health, but it's health care equals social determinants, including accessible and affordable health care that results in health. So I'm concerned that we're going to lose that common sense prevention approach to healthcare and to providing healthcare. And what we're learning and what's being published, the Kaiser Family Foundation did a research survey, it was reported in USA Today recently, that Obamacare has never been more popular than it is right here today. So we can credit Trump with doing something that Obama couldn't do, as one of the pundits said. But the more they tinker with it, the more you learn about it, the more you want to keep it. The more you want to not throw out the baby with the bathwater. And so there's things including, inpatient health, outpatient health, ER, things that are intuitive, but there's things like mental health, addiction services, preventive services, other things that you definitely don't want to throw out that, again, take that common man's common sense approach to the ounce of prevention. And lastly, I'll say the reason why that's so important, because we know that 75% of the drivers of healthcare expenditure are preventable chronic diseases that, if could be either thwarted altogether or at least delayed can save a heck of a lot of money and result in improved lives for so many of us, starting with the minority community. So I'll leave it there for now. Thank you.
Good morning. Can you hear me? Good. Obviously, my remarks will have to be brief. I don't have enough time to say all of the things that I'd love to be able to say in regards to this issue that we're talking about today. The first thing, though, that I want to make sure that you understand is that I'm absolutely opposed to Donald Trump. He's an idiot. He is, and I want you to join me in applauding that concept, that we have a crazy person who is running our government. And I'll come to the issues that deal with Obamacare or the ACA and Trump Care and all that in a moment. But the first thing that you have to understand is that we're dealing with someone who is not in his right mind in that position, that very important position. In fact, I invented a term to describe his mental state of mind. I call it, in medical terms, supratentorial apoplexy. I think those of you who were schooled in medicine understand exactly what that refers to. But we essentially have a person who is not really in his right mind and who has essentially strokes or seizures of mental illness which affect the American population. And that's not a good thing. Okay. So I hope that you agree with me that we have to absolutely oppose with all of our vigor the person who is in office first, Donald Trump, because he's the person who's the focus and should be the focus of all of these problems that we're having in trying to progress healthcare reform. The second thing that I want to mention is something that is sort of a quote from an old picture many years ago. It was a film that many of you might have seen. I can't recall the title of it, but it featured this young boy who was having visions of people who had passed away. And that was something that preoccupied him, and he was taken to hospitals and examined and so forth. His problem was something that I can put in other terms or express in other ways right now. He said, "I see dead people." And I think that you know what I mean when I refer to that term in regards to what the current administration has planned for the American population. They don't care anything about lives. They care only about money. And I call it a concern for wealth care, not health care. And I think that you have to look at it that way, because I do see dead people coming. I do see a future in which up to 14 million people over the next 10 years, over the next year, would lose their health care insurance, and 24 million over the next 10 years. In addition to that, just to put it in rough terms about actual lives that may be lost, if you take a look at the figures that were accumulated over the last 5 years of the ACA, it's estimated that 84,000 lives were saved due to the application of Obamacare. That means that if Obamacare is ripped out, if it is repealed, 84,000 lives will be lost over 4 years at least, and probably more. So we're talking real lives here. This is a life and death situation. We can go into all of the details, which we obviously are prepared to deal with on this stage. But the bottom line is we have to deal with the issue of saving people's lives. If we allow the Republican administration to prevail with repealing something that has obviously, documentedly saved lives, we have only ourselves to blame. And so I appeal to all of you to make certain that you approach this with vigor. Don't just read the newspapers or listen to the news. Do something to make sure that your views are represented, especially through our wonderful members of the Congressional Black Caucus, starting with Congresswoman Robin Kelly, who is fantastic. And thank you. The last thing that I want to do is to make sure that you recognize the tremendous talents of our moderator, who didn't say very much about himself. Dr. Daniel Dawes is incredible, and you should read his book, 150 Years of Obamacare, to get all of the details about what he has to offer. He said so much about all of us panelists up here. I think you need to recognize Dr. Dawes for what his talents are. So I'll say much more in the ensuing conversation, but thank you for the privilege of making some remarks to you.
Well, thank you very much, Dr. Williams, for those kind words. And, you know, I think there's a common theme of what we heard from each of our panelists. We've heard talk about the president's skeleton budget and the tremendous impact that would have on research and healthcare. And we heard, too, about legislation being introduced about racial and ethnic, prohibiting the collection of racial and ethnic data. But what we've also seen, just to couple that with some of the things we've been monitoring in terms of legislation, it's extremely frightening to us, is there is an increased introduction of legislation that would prohibit federal funding for racial and ethnic disparities programs and research. And they specifically target racial and ethnic and leave out the other pieces of health disparity. So that's very concerning when you add it to the data collection piece. We've also seen in the budget that, again, there is a significant hit to some of the pipeline programs, the Area Health Education Centers program, AHEC, HCOPS. Programs have also been slated for termination or a significant decrease in funding. We were also concerned early on this year with the Offices of Minority Health that were established by the Affordable Care Act at the 6 agencies, as well as the Office of Minority Health at HHS, that many of you know was established during the Reagan administration and codified in 1990. And folks, there is talk about either merging that with the Office of Women's Health or eliminating it completely or trying to figure out what else to do with it. So we've really got to keep our eye on those. And then we also I heard talk about the elephant in the room, the Affordable Care Act, and the serious issues impacting it. Should we repeal this law? Because, quite frankly, I do believe that African Americans and other minorities stand to lose the most under the ACA, and actually stand to gain the most should we expand Medicaid, et cetera. So there's still a lot left to do to preserve, again, the gains that we've made and to make sure that we are pushing forward on what's left to be done. So, you know, all of you highlighted some of these concerns. I'd be interested in your perspective about some of the strategies and tactics that we can use, that we can do to really push back on this administration and to push back on congressional attempts to undermine health equity. Ideas there for specific strategies and tactics that we can use. And feel free to open up whoever wants to start.
Well, I will offer this. I think that if you're dealing with an administration that really values ROI, return on investment, that really values saving money, decreasing costs, some of those things that we looked at in the triple aim that was introduced through the Patient Protection and Affordable Care Act. There is an economic case that can be made, and I alluded to it in my initial comments, and that is the preventable diseases that can be thwarted or delayed, the chronic diseases. I mean, that's really the elephant in the room when you talk about health expenditure. So there's those things, and again, if you're treating something at the front end, as we all know, it's going to be a heck of a lot cheaper than trying to treat and manage it at the latter end, certainly at the latter stages of life as well. And then when you're looking at certain populations, minority populations, immigrant populations, again, the folks who need it most are the folks that can benefit the most from the preventive care that happens on the front end. So I think you can make an economic case and say, if you want to actually decrease the cost of health care and health expenditures, let's put our investment on the front end upstream, and let's in addition start looking at some of these other contextual social determinants that we can also invest in, which can decrease that. So that's an opportunity. Now, is that going to sing? I don't know, but Republican administrations tend to think more fiscal conservatively, and I think that might be an avenue to make the case.
So can I actually ask you, when you talk about making the economic case, we've heard that in Georgia, we live in a very red state, as you can imagine. Folks want to know what's the cost burden, and then what are the cost savings from some of these policy recommendations that we make. Anywhere we can go to get that type of information? Any studies out there that we can use to drive home that point? Are you familiar, anyone with those?
So I could share some of the experience that I've had working with the American Society of Pediatric Nephrology. Though we are a relatively small organization, I'm a trainee member of the Public Policy Committee. We have a pretty robust advocacy arm. And we've been able to put together data that reflects the costs to Medicare. As some of you may or may not know, pediatric end-stage renal disease is the only pediatric indication for which Medicare is a payer. And so we've been able to share some information about the relative cost for instance, a patient on dialysis, which is roughly a little bit over twice as much per year as a patient receiving a kidney transplant. You can imagine that there are a variety of health disparity implications related to transplantation, particularly within minority communities. So this information has been collected and distributed by our professional society, and I imagine those of you who are parts of subspecialty groups or professional societies in healthcare might be able to call on your national organization to provide you with some of that data. It's also talking about the economic case for the Affordable Care Act, and by extension, the comments that were made by Dr. Winn regarding the president's skinny budget proposing a 20% cut in the NIH. I was recently on a Hill visit, again with the American Society of Pediatric Nephrology. We were advocating around a few issues that are of concern in our community. One of the things we brought up with regards to NIH funding was the fact that there are other countries that are outpacing the United States in medical development and in their workforce. When I mentioned, for instance, that China and Europe have dialysis modalities and therapies that we do not have available here in the United States, and that children are being dialyzed, premature babies are being dialyzed with a hemodialysis machine that is sort of crawling its way through the processes here in the United States, the folks in several of the Southern Republican senators' offices sort of perked up. So there are definitely areas of common ground where you can find opportunities to leverage a common cause and provide a financial argument to support medical research and a lot of the work that we're trying to do.
I'd like to make a comment in regards to the whole concept of trying to cut your way into some kind of increased efficiency in healthcare delivery. You can't do that. You're not going to reach increased efficiency, effectiveness, have increased safety and so forth by making cuts in vital programs, such as the research programs that you've just referred to. Now, one of the most intuitively brilliant parts of the ACA, which has not gotten much recognition, is the fact that there is a focus on wellness and on preventive care. These are the things that we need to have our government focus on and continue to focus on for the benefit of the American people, not cutting programs that are intended to try to progress healthcare reform and better healthcare delivery. One of the programs that is at risk of being cut is not completely a government program, it's quasi-government, and that's what we call PCORI, the Patient-Centered Outcomes Research Institute. Many of you may not know about PCORI, but it is focused on the concept that we have to make certain that the patient becomes the center of the medical universe, not the doctor, not the healthcare providers, but that we focus on patients and on the patient, the doctor-patient relationship, and having the patient as part of the decision-making mechanism in medicine. It has done a wonderful job. It was originally funded by the ACA with $19 billion. Those $19 billion are going to go by the wayside, almost certainly, with the repeal of Obamacare or the ACA. That's something you may not recognize as being important, but it is vastly important from the standpoint of moving the needle forward in regards to better healthcare reform in this country. So those are some of the things that we have to keep in mind and have become aware of. There are things that fly under the radar. You've got to you have to be more vigilant and much more attentive to what is in the offing in regards to what Donald Trump wants to do to dismantle the ACA. There's a lot more at stake than meets the eye, and you need to make sure that you stay vigilant.
So to that point, we talked about strategy, and so for a moment, I'm going to suspend my academic self and get forget the eruditeness of this conversation, and go back to one that was simple. With a couple of weeks ago, I had with my grandmother. We were talking about these issues. Now, she has a very straightforward way of sort of talking about these things, and she's always calling me for not only medical advice, but apparently not political advice, which I can't give it. So but she had this interesting concept that what we're arguing about makes no sense. And she said, baby, this is like going to the store, you buy a pair of shoes, all of a sudden you get the shoes and it fits mostly well, but yeah, it's not perfect. You know what you need to do, you just need to wear it a little bit. She goes, you wouldn't take the shoes and repair it, that don't make sense. And you certainly wouldn't replace it. She goes, what are you gonna replace? You're gonna get the same shoe or maybe something worse. And I started thinking about the wisdom of what she was talking about in the context of this silliness of talking about what doesn't work when the reality is you haven't really figured out what is working first. As a scientist, you're always taught to look at the data, not alternative data, because we don't have that in science. I'm sorry, but that is the basis of science. It's based on that. So, when you start there, you start thinking about what it is that we're going to do. So you talked about strategy. The strategy for me is just basically simple. It's not academic. It's doing what happened this past weekend, getting a group of scientists, which is never, and they should have been doing it long ago, where scientists are sort of saying, we also represent the people, and we also want to impact the people, and we're going to go out in the streets, not only here, but all over the world, to say that this is important. But in addition to that, when logical arguments fail, this is what's called midterm elections. And so at the end of the day, I think we cannot fail again in not showing up, simply put. Simply put.
Well, I know we have less than 20 minutes to go, and I think we should open it up to audience question and answers. Anyone has a question? If you do, we have 2 microphones, I believe, or is it just 1? Oh, 2, yes. 1 on each side of me right here. So if you would come up, please, and ask a question. I see Dr. Joya.
Yes, you know, Daniel, I had to come ask a question.
Yes.
Good morning, everybody.
Good morning.
It was a great panel. You know, I was just thinking about the strategies you mentioned around resources and combating the current Trump care, but, you know, at the core of it is about racism, right? And we have to be honest about that in this space. And so how do we combat policies that are built around race and dividing us among race and among gender and all these other things? How do you have a strategy? Because talking about economics, like in a state like Louisiana, we can talk about that all day, but if the core of their issue is not going to be about really economics, then we have to be honest with ourselves about that. So.
Excellent point. Anyone wants to take that?
Yeah, well, to me, it is a matter of kind of what comes first, the chicken or the egg. So to me, they're very inextricably linked, racism and economics, and we know there's an income gradient, there's an education gradient to health, et cetera. But when you're talking in this age that we're in, where there are alternative facts and there are other agendas and hidden agendas, it really becomes about tact to me, strategy, tactical strategy. And so the way I would do it, and the way I've argued it in the past, begins with the economic argument, which pulls along the racial folks that are most vulnerable. So the argument would go like this: if you believe that healthcare is too costly, then you might believe that if we focus on prevention, we can save money. If you agree that we can focus on prevention that'll save money, you might agree that we need to give prevention to those who need it most. We'll get the most bang out of that buck by going to this community versus this affluent community that doesn't need it as much. And if you believe that, then you're going to necessarily be dealing with lower income, primarily minority population, immigrant populations, and you're going to seed your investment there. So that's kind of the chain that I would use. Again, when you're dealing in this alternative universe that we're dealing with, you can't legislate moral high ground. You can't legislate the dismantling of racism. That just is not the lever. It's the right thing to do, but that's not the lever that's pullable at this point in time. So my tact would be working it that way.
I have a quick comment on that as well. We in this room are at risk of becoming an endangered species. You've heard about the possibility of cuts to PCORI funding, NIH funding largely. One of the things that a lot of people are not as familiar with, perhaps, that also came out of the Affordable Care Act is something called a community benefit. So every hospital, not-for-profit institution in the United States is required to document how much they're contributing to the overall benefit of a community in order to keep their tax-exempt status. Used to be that you could write off your steak dinner for your, the fancy doctors at the hospital as part of community benefit for your institution. The Affordable Care Act instituted regulations that required that community benefit actually mirror the needs in the community. Okay, now this is something that's personal for me. One of the reasons why I became so active in advocacy in Cincinnati is because I had the opportunity to work with a group of inner city fathers in one of our very impoverished high crime neighborhoods. These gentlemen, so I established a relationship with these gentlemen first. To the previous panel's point, I gained their trust by being genuinely involved in the work that they were doing, and had an opportunity also to write a grant through the American Academy of Pediatrics to do some work with them. It would be a shame if we allowed the work of institutions like Cincinnati Children's or the institutions that you come from to not mirror the communities that they serve. Most of the fancy hospitals in the cities where we care for patients are in some of the worst neighborhoods in our cities. So to imagine that we are going to allow ourselves to sort of lose the opportunity that all of us in this room have to care for communities that look like us is a real shame. We have got to start speaking up and, I would say, empowering our patients. Every other industry does it. Why can't we start talking to our patients and letting them know, by the way, this ACA thing, this is how it relates to you. This is where you're getting your coverage from. When people started realizing that Obamacare was the Affordable Care Act that they got their health care through, they started freaking out and calling their representatives. That's precisely what we need to be doing. People need to know that the reason you have this program in your neighborhood is not just because the hospital put it on. It's because someone like me or one of the other people on this panel wrote a grant and asked for money from an institution like Picori, which might be going away, and so is that program that you depend on every year. So these are the sorts of things that we need to be doing. We have to start advocating for ourselves, standing up, and then empowering our communities to partner with us to advocate for these issues too.
Dr. Winn, quickly, and then we're going to go to our next question.
I was just going to say real quick, we also can't make another mistake. The reality is we know that there's explicit and implicit biases focused on race, but we also have to add to that conversation the capital A-N-D, also the silent warfare that's being waged on class. And in fact, if we actually start talking about how do we get back together, then we actually have to recognize that there is pressure being put on classes. And those classes actually aren't just coming from our communities, they are coming from the BDV of Kentucky, who may sometimes be buying into something almost like the Running Man that just ain't there. And so if we are really about all of us, the truth of the matter is, and we need to be about us, and that is race, and we need to get back to talking what we were talking, Fred Hampton and everybody else, it wasn't just about black power, it was about people power, right? And so there is this context that I think that we also are obligated to sort of figure out what we're going to do with our race, Latino, African American, whomever, but also class, because that class war is not so silent these days. And in fact, it erodes, I think, a lot of what good could come out of it. So again, just being mindful of that.
Thank you. So,
Absolutely. Good morning. Good morning. My name is
Before you
Jean
go on
Drummond.
to the next question, I just want to mention a couple of things that folks might want to look into, and this refers to the question and the comment that Joya mentioned. I think it's important for us to look back in history at some of the theorems that have come out of some great scholars, such as the economic theories of Adam Smith on the wealth of nations. And one of the clear principles that came out was that nations will never achieve, according to Adam Smith, great wealth by focusing on the poor. This was the person who was recognized as the world's greatest economist back in the 19th century. But that's where a lot of the current theory of the wealth of nations comes from. This, of course, was opposed by Karl Marx, and no matter what you say about Marxism and all of those theories, the attempt was to try to write the concepts and give a proper due to the needs of the poor in regards to what the wealthy nations would, how they would treat them. The last thing that I want to mention is another theory which came from England. There was a gentleman named Tudor Hart who had a theory of what was called the inverse concept of economic benefit. Basically what he said was that the people who need economic help most are going to be those who receive it the least. And that is something that is a dictum that is followed by wealthy nations. We have to recognize, therefore, that poor poor, black, and other minority people are not going to be benefited by governments unless we force them to do that. We have to bring this to the fore, recognizing that the odds are against us, and that racism is alive and well, and that it needs to be treated, as Dr. Alvin Poussaint said, as a disease. Racism needs to be recognized as a disease that needs to be treated in our society. Thank you.
Great. Good afternoon. I think it's good afternoon now. My name is Jean Drummond with Healthcare Dynamics. What an incredible panel. I mean, you all are just absolutely stellar. So I want to kind of come from a policy and economic venue, if you will. And so certainly we know the ACA, but I also want to ask you about MACRA. Because certainly, you know, that came under President Obama's administration. And just kind of thinking about how MACRA is really going to impact incredibly. If we're talking about economics, right? If we're trying to drive policy, it has and will continue to change the way clinicians are paid. So I've got a solution and I've also got an answer. So we are thankful that in working with the NMA and the Hispanic organization, we were able to secure funding to provide support for every clinician that is in need of support around MACRA, so I'm happy it's free. I want to be here for you. We have that. So because ultimately we need you to stay in business in these communities, and the way MACRA is going, you could decide to retire, leave, go be brought up by a healthcare system that won't treat you culturally appropriate and does not understand health literacy in our communities, and all of that's lost. We don't even want to talk about the rural communities and how far they'll have to go. So my question to you is, in terms of how do we help our clinicians to understand this policy impact? I mean, this work begins years ahead, and oftentimes the doctors will say to me, Jean, I didn't even know this was going on. And it's going to impact how they practice. So oftentimes as we're giving out this free support to them, I'm also trying to help them to understand the rulemaking. And I know they didn't go to school for that, but it impacts the economics and the sustainability of your practice. Help me.
Great question. I'm so glad you brought that up, because I think it ties in with what Dr. Williams was saying earlier about this notion of increased efficiency in the system. And actually, this is a really, really good topic, because we think that Secretary Price, we think that the Trump administration, as many of you recall during his campaign, he said he really wanted to work on improving the quality of care for all Americans. Improving the quality. MACRA was designed to really push us and drive this quality improvement initiative. But what we have seen in communities of color is very interesting, is that in the South tends to have lower quality scores, okay? The North and the Midwestern states tend to have higher quality scores. But here's the kicker. So while we have to improve the quality of care in the South, in the North, where they have the highest quality of care, they actually have the highest racial and ethnic health disparities. So we have a lot to do to address the intersection of quality and disparities as we move forward. So I'd like to hear your thoughts on that, because we know that this is where the Trump administration really wants to push in terms of one of its key reforms moving forward. What do you all say to Jean's comment?
Well, if you focus on MACRA alone, what you need to do, first of all, is understand what its basis is. It's focusing on Medicare. Medicare is under duress now in regards to what Donald Trump has planned for it. And people who care about Medicare need to be vigilant because Trump has designs on it. He's going to destroy it based on the notion that Medicare as it exists today is not a good thing, that it needs to be changed, and that the changes will benefit the American public. It will not. So the first thing is that people need to be very careful that Trump does not get rid of our Medicare, which has been in place since 1965, and something that the National Medical Association fought for to make sure that all of us are beneficiaries. So as far as MACRA itself is concerned, I think that black doctors in particular, minority doctors in general, have to be very careful because of the fact that if you're not cautious, you're going to be shut out. You're going to have worse conditions than prevail now. The whole idea is that we're going to replace a volume-based system with a value-based system, which sounds great. No problem with that. We want to have higher quality medicine delivered. However, it may be at the peril and at the jeopardy of physicians who are not allowed into the system or not allowed to benefit from the system fully from the standpoint of the remuneration that they will receive and the kind of patients that they're able to continue to practice among. So the main thing is for all of us to be vigilant, again, and to become educated about what MACRA means, what it means to all of us. Don't accept it on whatever Trump is attempting to put over on us at face value. Look behind it, because you'll almost always find that there's something worse there than you imagine.
Thank you, Dr. Willen. So we have less than 3 minutes to go, and I want to get in as many of our questions as we can, so let's go over here quickly, and if we can answer them quickly as well. Yes, ma'am.
Yamile Molina from UIC. Thank you all for being here. I just wanted to return to the idea of data collection and our unique potential ethical dilemmas as scientists in this new administration. And so there are items that are being discussed in terms of whether we should or should not analyze or use funds for the analysis of racial ethnic disparities. There also are certain data that potentially are dangerous to collect, especially if you're working with Latino communities, immigrant communities. For example, at this point in time, standardized questions through the births in terms of country of birth, in terms of how many years you've been here, certainly not in terms of documentation status. All of these questions at the individual level are going to be are already becoming very dangerously difficult to collect. And as we think about this is not only the Trump policy, but it's also in response or preemptive policies that certain academic institutions have when they are perhaps requesting certain information in order to be in line with IRS or other policies that may or may not have been enforced as actively, and people are already nervous at the institutional level. We come into the situation where we want to collect data, we want to be scientists, we want to document the problem so we can address the problem, and our participants may or may not trust us, getting back to that first session, with reason, right? Because there is potentially a system where the investigator is not in a vacuum and cannot necessarily control what would happen or not happen, right? And some of this is fear, there are political safeguards, right? But there's an increasing concern potentially in terms of whether we should or should not be collecting data that are standard. And this is in the face of the ACA, right? This is in the face of us wanting to collect better and continuous data on race and ethnicity, for example, with hospital records. So in a couple of senses, what should we do in this era where we want to collect data and at the same time we potentially have to be thoughtful about how we collect data to ensure that our participants and our patients are protected to the fullest? Gracias.
Quickly, anyone have a reaction?
I was just going to say that, again, underline that, the thoughtfulness of data, but let's not forget that data and the lack thereof about populations actually also is harmful. But again, the thoughtfulness around data we need to do, because I see big data and data as social justice. The fact that we refuse or have very little data, or for example, Native Americans, because we say, well, our tools won't actually really measure that accurately, means that we don't see Native Americans. They're invisible. And so we shouldn't collect data to actually improve their health. So again, underline thoughtfulness of collecting data, thoughtfulness of dissemination of data, and thoughtfulness around data is absolutely key.
Okay, we're going to go over here quickly, get your question. Thank you.
My name is Bernadine Lacey, and I'm retired, but very active in the National Black Nurses Association. This is not a question. I want to ask for your support. As most of you know, the President has relieved the Surgeon General of his duties and thanked him. But the good news is Rear Admiral Sylvia Trent Adams, a nurse, is now your Surgeon General. And I ask you to please, wherever possible, give her your support. She's a dynamic young woman and a colleague of mine in the Academy of Nursing. Thank you.
Very good. Thank you. Appreciate that. And our last question.
Good afternoon. My name is Wanda Bell, and I live in Baltimore. And actually, part of my question was that the Surgeon General that was fired, part of the reason they think that that happened was his stand on saying that gun violence is a public health threat. And, you know, living in Baltimore, just this past weekend, they said we've reached 100 homicides. And that's the first time that's happened within the last 20 years almost. So my question is, you know, in light of all of the healthcare discussions that we have around chronic illnesses, how do we integrate this discussion, which is truly a crisis in many cities in our country, into our thoughts and strategies?
So I'll take it real quickly. This is something that the American Academy of Pediatrics has, for quite some time, put a lot of effort behind. I'll just provide a brief anecdote about one of the ways that this advocacy through the AAP has yielded some results. The Ohio chapter of the American Academy of Pediatrics has been remarkably active, period. And it's also been very active around this area. However, there are a number of challenges in terms of the language that you use to describe your advocacy efforts, who you engage about it, etc. These are tough times. We're kind of preaching to a choir here, it sounds like, because the music coming from you guys is amazing. But I think that we need to be really deliberate about how we engage others on the other side of the argument. The Ohio chapter of the AAP has recently had a really remarkable project where they distributed gun boxes and locks to individuals in the community by engaging the local chapter of the NRA affiliate and just sitting down with them and saying, can we approach this issue first by talking about unnecessary deaths due to accidental firing of firearms? That was something everyone at the table could agree on, and they were able to make a step in progress to be able to distribute these boxes to the community. They actually were out ahead of the Hospitals Association on it. I think if we start finding those areas, particularly for me in a state like Ohio, it's a swing state, it's a very red state. The part of the state where I am is very red. And I think that we need to start being very intentional. If we really want folks to make changes and impact, we got to start finding some common ground and move on the issues that we can move on. And I would encourage you to do the same in your area.
Thank you, Dr. Bignall. Yes, last comment before we close.
Start the comment by saying that silence invites violence. And what I mean by that is that the more we are silent on the gun violence issue, the more violence there's going to be. It obviously is increasing, not decreasing. We're not speaking out enough about it. The National Medical Association is taking a lead role in speaking out. We are developing a white paper on violence and the police use of force. We are looking at this as not just a problem, but a public health issue. It is a public health issue. Obviously, it threatens the lives and health of all of us. And we have to do more about it. The NMA is trying to take a lead in that. We're trying to do that in conjunction with the Congressional Black Caucus. In September, we intend to present our white paper, our position paper on this issue at the CBC Foundation meeting here in Washington. And we invite you all to join us and to take a part in this very important dialogue.
Thank you, Dr. Williams. And let's give our panelists another round of applause. Thank them. There certainly is never enough time to give these issues justice, but I do thank you for your very thoughtful comments and insights. And just wanted to let you know that lunch is outside the doors, ready for you to pick up and come back in for the award ceremony, okay? Thanks again.